paucity of time.
15
Thank you, sir.
minutes. So we'll
Go
start.
ahead. Thank you, sir.
Respected chairpersons and dear friends, we'll be changing gear. We are today here to discuss something little different and something more that we want for diabetes care. I'm going to talk about the diabetes distress, the transcontinental perspective. I have brought for the focus a tale of two continents of the diabetes distress. One continent is the European continent and the other is the subcontinent of India. And I like to show that how these two countries, this diabetes distress has produced synergy, has produced amalgamation, and has produced great way to take it forward. Now, diabetes distress is a topic you will realize maybe at the end of the talk is the most contemporary and most challenging issue because it has taken the center stage today. Now, in Indian perspective, in our adaptation, we view diabetes distress as a great impactor of the glycemic control. And if you look at the EASD 2026 guideline on diabetes distress, it also realizes that diabetes distress is a great helper for the diabetes becoming on control and to bring back diabetes on the rails. Therefore, dear friends, we'll see both the guidelines. We'll see that how both the guidelines are looking at the same thing from different angle and how they can both contribute to the well-being of the diabetic patient. Now, dear friends, suffice to mention, there's an alarming rise of uncontrolled diabetes. Very brief to mention that about 50 to 60% of type 2 diabetes have H1C at least above 8%. And prolonged hyperglycemia gives rise to complications. But there are a lot of younger patients we had discussed in the previous session also, less than 40 years in type 2 diabetes in India, who have longer disease exposure and they have cumulative glycemic problem. So therefore, very important to remember that the factors that contribute to the uncontrolled diabetes like the dietary challenges, or like the not availability of the good care, not availability of the drugs, the economic problem are all looming large on the Indian patients. In spite of that, if we can take care of diabetes distress, we make a great change in these patients. Now, how poor control also fuels distress. Now, worsening control, the glucose level further rises and there is reduced adherence. When somebody sees the glucose is still rising, the adherence comes down and there is a motivation for self-care also decreases. When the distress increases, there is emotional burden and due to the unmet targets, and therefore there is elevated H1C and poor control. So this particular cartoon shows the vicious cycle, how control fuels distress and how distress can give rise to uncontrolled diabetes. Now in the young onset diabetes, it's a double burden because these people are more exposed and they're more sensitive. They consider diabetes as a stigma and they are the people who get maximum distress because of diabetes and must be taken care of. Now, if you look at the DRD or diabetes related distress, that impacts glycemic control by reduced motivation and poor adherence. I'll be very fast to finish in time. Now, why we should address the diabetes related distress? Number one, if you address this by the ways available today, you can improve self-management, you can enhance glycemic control, reduce the risk of complications and produce a lot of support for the mental support. Now, 2026 is the guideline on diabetes distress came only this year, 2026 in the EASD 2025 and these practical guidelines have two things, assessment and management of diabetes distress and I'll put it before you. Number one, what is the rationale? They said that there is a lot of emotional burden of type 2 diabetes and therefore taking care of this burden is very important and there is also a psychological burden. You know, diabetes distress is not same as diabetes depression. Diabetes distress is limited to the distress the person with diabetes has in regard to the management of diabetes. I'll repeat again, distress in regard to management of diabetes, but diabetes depression is a more general thing. We are talking about that EASD guideline and Indian guideline both have said that it is very important to provide the emotional support and psychological support to bring down this particular distress. And there are many unanswered questions which EASD last year put forth, which we had answered before in India. It says that is this. What is the difference between distress and depression? I told you just now. Now, which screening tool we must use for diabetic distress? How can I have effective conversation with the patient to reduce his distress? And what structured approaches should I offer? Now, long before this came, in India, we had this issue of biopsychosocial aspect of diabetes. And one of our doctors, I'll come that at the last slide, did address this by saying that it must be included in the standard of care that ADA publishes every year. And with that letter from our group led by Dr. Sanjay Kalra, the ADA adopted, and all the standard of care today has the biopsychosocial aspect. There we said that listening to the patient itself is the beginning of relieving diabetes stress. The cure begins much before the treatment is given if you give a good hearing. We have also said how one can address diabetes stress by taking care of smaller things in diabetic care. Now, what are the objectives of evidence-based care by the EASD guideline? They recognize diabetes stress as core element in both type 1 and type 2 diabetes. We have not yet recognized, support standardization of the assessment and management. We have said we are bringing out a core guideline how to assess and how to manage diabetes stress in clinical practice, provide good practice statements and good practice conversation. We call it viscerometabolic conversation, and good assessment, and a grade-based, GRAD, grade-based, the evidence grade 1 to 4 for recommendation for the management, and support the person-centered evidence-informed care. Now, there are few clinical questions. This guideline of EASD addressed management and assessment. Management, what is the most effective psychological, organelles which can be addressed by this and managed by this, and they said how to address this, how and when to assess diabetes stress among the adults with type 2 diabetes or type 1 diabetes. But this was done in India much before. Now, what are the good practice statements for the assessment of diabetes stress among adults with type 1 type 2 diabetes? The healthcare professionals should discuss the emotional side of the diabetes at every stage. We should also ask about diabetes distress using open-ended questions. The questions are available today. And we should assess the diabetes distress using a valid and reliable tool, and also monitor this with the tool, and should acknowledge and discuss the person's assessment irrespective of the findings as part of effective person-centered care. A healthcare professional should record the findings of the distress in the clinical record. Now we are trying to make it possibly at least basically mandatory. When diabetes is identified, healthcare professionals should make a joint plan with whatever psychologist or whoever available with the family members to take note of that. Now, how does implement and impact the guideline? The limited consultation time, that's a big issue. These are the barriers. We have lack of SCP trained in psychological assessment of diabetes stress, insufficient access to mental health services for many parts in our country. Provide the foundation for the professional training is important, and support service development is important. So this embeds emotional support which must be available, and there must be growing awareness that diabetes distress is ingrained in every diabetic. If we can find it out, give a patient hearing and provide support by your language, by your speech, by your medications, by listening to him, by allaying the apprehensions, reducing complication, and a non-diabetic, better than non-diabetic, he lives longer. But if you take care of him, and it offers a timely, essential framework for addressing distress, which is potential to improve both the experience and the outcome. In the Indian context, the high baseline HbA1c is a distress amplifier. Now, Indian studies have shown that diabetes distress is correlated with HbA1c, and there is a dose-response relationship. Those who have H1C more than 10, the distress is 3 times higher. Therefore, there should be consistent across all age group to control blood sugar as much as possible, and glycemic control is a very key modifiable risk factor. The other approach that I must address is the mind-body medicine approach. A comprehensive review of the psychosocial impact and clinical management is mandatory. Now, Endocrine Society of India has accepted our group as the mind-body medicine group under this, and Vaishali Desmukh, who many of you know, is one of our chief doctors who is leading this. So, we said that if possible, a comprehensive review of the psychological impact and the clinical management should be addressed to that. But what does mind-body medicine mean? It means that is an integrated approach, not only physical, recognizing the connection between the psychological, behavioral, social, and biological factors. It may seem very rudimentary, but it's important, and emphasize the bidirectional relationship between mind and the physical health. Now, historical evolution I told about, that first to point out was India. Biopsychosocial dimension to be included in the ADA, the standard of care, by Dr. Sanjay Kalra in 2016. And there's an ancient holistic medical tradition. And we have a system today by Government of India called IKS, Indian Knowledge System. And there's 3 volumes are being produced. Indian Knowledge System and how diabetes has featured in that. I'll bring those volumes next time. It will be published by that time. There is a modern psychosomatic medicine emergence in 20th century. Neuroendocrinology and stress physiology is paramount, and integration into contemporary care is also very important. What are the core principles? Mind and body are interconnected systems. Emotional state affects physical health outcomes. In diabetes is more true than others. Holistic assessment and treatment is required. Patient empowerment and self-care is important, and evidence-based therapeutic intervention must be given. Therefore, before I close, one must understand diabetes distress. Emotional psychological burden of living with diabetes is distinct from general depression, and it is specific to managing a chronic metabolic condition, very important. So, distress, as I told you, is the burden specific to diabetes management and disease control. Whereas depression is a broader mood disorder affecting multiple life domains, not only management domain. Now there are few data from the IDF, and India is a great contributor of those data also. 77% of the people with diabetes experience mental health conditions, and 50% of the US adults have moderate to severe distress by the CDC data. 46% in Africa, 86% in India report mental health issues amongst diabetics. Emotional burden most prevalent in type 2 diabetes mellitus, and complication increases threefold. Now, what are the primary distress triggers? 83% fear developing complications. I'll take it to 1.5 minutes. 76% burden of daily management and monitoring is because of primary distress triggers. And there is stigma and discrimination that gives rise to more diabetes stress that must be taken care of, and 55% needle phobia and injection phobia. There is also the last thing I'll point out, there's a diabetes burnt out impact. Now 9 to 80% diabetes experience diabetes burnt out. They accept as diabetes as it is, do not put out any effort to control it, and there is interrupted treatment. They take some time, don't take treatment sometime. In Brazil, 80% have this burnt out and the treatment is interrupted. The stress leads to non-adherence, poor control, and increased distress. I'll come to the last slide. Before that, I must tell you that there's a primary emotional response which one should take care of. Behavioral impact is also important. And there are assessment tools. I have given the T2 DADAS and T1 DDS, which are the tools, and also the psychological tools, DDS 17. There are 4 domains, and PHQ 9 and GAD 7 for the comorbid screening. I will not go details of it because we're late because some regions. I'll end by saying that in India, the psychosocial and bio-mental aspects are built in. Very important to remember that if you want to contribute in one area in diabetes care, which is based on psychosocial aspect, biosocial aspect, biopsychological aspect, we can really make a mark. I will end by saying that if you look at a quotation which we have given in that volume of Indian knowledge system from a national freedom fighter and a seer from the city I come from, Sri Aurobindo. He said that India has to be the leader in the world of mind and spirit. Not only physical medicine, but in the mind and spiritual medicine, India has to be leader and a friend and helper of all people. Like many other fast, like use of metformin, like giving rise to screening context. And India also is a leader in the mind-body medicine and the diabetes distress annihilation. Thank you.